Welcome to this session on genetics in primary immunodeficiency. I'm going to talk quite slowly because participants are only just joining the session. We've had lots of interesting submissions on this topic to the conference, and I encourage you to go and look at the e-posters that are also available in the e-poster lounge. For the session this afternoon, we've invited a selection of speakers who bring posters on different aspects of the subject, from some rare cases through to functional validation and how to run a diagnostic genomic service in primary immunodeficiency. And the format will be that each speaker will have 5 minutes to present some slides representing their poster, and then we'll have 2 minutes for questions. And you, the audience, are encouraged to submit your own questions using the Q&A functionality on the Zoom screen. And I hope we're all, unfortunately, extremely familiar now with Zoom after these months of COVID. So sorry that we can't all be present together, but I'm sure that we're going to have an interesting session this afternoon. I think if the speakers don't mind, we should make a start. Will gain us an extra couple of minutes of discussion at the end instead of listening to me. Oh, except one thing I forgot. I am not the only chair of this session, and Puel is on the call, and give everyone a wave. Sorry.
No worries, Sophie. No worries.
It's like Eurovision. Okay, so our first speaker is Dr. Alexander Grammatikos from Bristol in the UK, and he's going to be talking about a family with a novel CTLA-4 haploinsufficiency mutation and neurological symptoms. Thank you very much.
Thank you. So my name is Alexander Grammatikos. I'm a consultant clinical immunologist at North Bristol NHS Trust. And I will present this family with CTLA-4 haploinsufficiency. I have nothing to disclose. So CTLA-4 is an inhibitory molecule, and it is present on the surface of activated T cells and T regulatory cells. And it is important in the process of antigen presentation. So in this process, antigen-presenting cells present antigens to T cells. And when there is a co-stimulatory molecule CD28, then we have T cell activation. But when we have CTLA-4, which is an inhibitory molecule, then we have T cell inhibition. So it is not surprising that when we don't have CTLA-4, then we have T cell hyperactivation with resulting lymphoproliferation and autoimmunity. So CTLA-4 haploinsufficiency is a rare autosomal dominant disorder. And as you can see here from this family tree, these are the 3 cases I'm going to present. But the extended family tree as well had many medical problems, autoimmune cytopenias, Evans syndrome, lymphadenopathy, brain tumor, unexplained early death, and leukemia. So starting with the index case, case number 1, she presented at the age of 45 with vertigo, seizures, and right-sided facial dysesthesia. She's had oligoclonal bands in her CSF and a raised serum anti-thyroid peroxidase antibodies, but normal thyroid hormones. Her MRI of her brain revealed a right middle cerebellar pedicular mass, as you can see in figure A, and she's had a brain biopsy which revealed a demyelinating process with a florid inflammatory infiltrate. She was treated with dexamethasone, and this was successful. This resulted in a gradual reduction in the mass size, as you can see in B and C. Case number 2 was the daughter of the index case. She presented with severe headaches at the age of 12, and again she had abnormalities in her cerebellum in MRI imaging, a high signal intensity in her right cerebellum, with a small gliotic change in the left superior frontal gyrus. Case number 3 was the son of the index case and presented with memory decline, incoordination, hallucinations, and that was at the age of 29. He had a normal brain imaging, but had raised anti-glutamic acid antibodies, and that was both in his serum and CSF. He also had oligoclonal bands in his CSF, which could reflect intrathecal synthesis. Genetic analysis of all 3 family members confirmed mutation in the CTLA4 gene in exon 1. This was a novel frame shift deletion mutation with a duplication in cDNA position 81 and the introduction of an early stop codon and the truncated CTLA4 protein. So, in conclusion, this family presents some interesting clues with regard to the pathogenesis of neurologic symptoms, not only for CTLA4 haploinsufficiency, but even for more prevalent neurologic disorders. For example, lymphoproliferation with the subsequent mass effect, which was seen in the index case, at least partly explains some of the symptoms. But also demyelination was seen in the index case, and this could have been autoantibody driven. For example, glutamic acid antibodies and TPO antibodies have been linked to encephalitis under certain conditions. In conclusion, neurological features are well described in CTLA4 haploinsufficiency, up to 29% of these patients in a recent case series, and there should be a low index of clinical suspicion for these symptoms in these patients. And I would like to thank Dr. Sarah Johnson and Dr. Mark Gombels, consultant clinical immunologists at North Bristol NHS Trust, and Dr. Claire Rice, consultant neurologist in the same hospital. And thank you very much for your attention.
Thank you very much. Thanks. So I get the luxury of the first question. So when you looked at these patients immunologically, did you find anything, or was it all blameless? They had autoantibodies.
Yes. They had low B cells, 2 out of 3. They had low immunoglobulins. Actually, that was only found in only one of the 3 cases, which contradicts previous findings that it seems to be more common actually in other patients, but in our patients it was only seen in one of the 3. And I think everything else was fine. I don't think we find any other abnormalities.
So how are they being managed?
Most of them, two of the 3 patients are treated with sirolimus and they respond well. And the other patient is on immunoglobulin replacement, the patient with the low immunoglobulins, and she's also on azathioprine for autoimmune hepatitis. And
did you pick up any more cases in that extended pedigree among asymptomatic individuals?
Not yet. No, we are in the process of doing that, yes.
Very interesting. If there are no more questions right now, I think we'll move on. Thank you very much, Dr.
Thank you very much.
So our next presentation is from Rebecca Perez de Diego in Spain, and she's going to describe to us human BCL10 deficiency due to homozygosity for a rare allele. Thank you.
Well, thank you very much. Hello, everybody. Well, studies have reported human inherited defects in the 3 components of the CBN complex, CAR9 and CAR11, and the 2 core components, BCL10 and MALC1. In terms of BCL10 deficiency, the only one reported to date was a child with a broad combined immunodeficiency who was homozygous for a private BCL10 allele. Here we studied an Indian child with a related combined immunodeficiency phenotype and a new autosomal recessive BCL10 deficiency, highlighting the non-reducing role of the human BCL10. The patient is an Asian Indian boy from India with consanguineous parents. At the age of 1 month, he developed a flare on his BCG scar with increased erythema and swelling. At 6 months of age, the patient was admitted to the intensive care unit due to a severe viral lower respiratory tract infection and palatal ulcers. At 8 months of age, he suffered acute onset respiratory distress with rapid worsening. Bilateral chest X-ray showed hilar infiltrates, and mycobacterial tuberculosis culture was negative. He also suffered 2 episodes of lower respiratory tract infection, non-requiring hospitalization at 8 and 10 months of age. And he also has hypogammaglobulinemia treated with immunoglobulin therapy. Well, but by next generation sequencing primary immunodeficiency gene panel, we detect a variant in BCL10 gene who was homozygous nonsense mutation, who changed an arginine in position 88 by stop codon. And this variant was previously reported as a rare allele in heterozygous. Next step was to check the protein expression, and no protein expression was detected on Western blots of BCL10 deficient SB40 fibroblasts transfected with the arginine 88 stop codon, BCL10 plasmid, while we detect protein expression when we transfect with a wild-type BCL10 plasmid. So this patient presents autosomal recessive complete BCL10 deficiency. We wanted to check the impact of human BCL10 deficiency in fibroblasts, so we transfect the arginine 88 stop codon BCL10 plasmid, and we compare with a wild-type BCL10 plasmid or mock vector in SB40 in BCL10 deficient SB40 fibroblasts by measuring the production of interleukin 6 and interleukin 8 after stimulation of TLR4, TLR2 and 6, Dectin-1, and TLR3. As expected, TLR3 cycling was BCL10 independent. However, TLR4, TLR2 and 6, and Dectin-1 cycling pathways were abolished in BCL10 deficient cells transfected with the arginine 88 stop codon BCL10 plasmid. In terms of adaptive immune response, there is a deficit of memory T and B cells. There is a reduction of CD4 positive central memory T cells, and also memory B cells are reduced much lower compared with Elsink donors, which is consistent with the profound hypogammaglobulinemia of the patient. So we can conclude that we identified the second patient with an autosomal recessive complete BCL10 deficiency. And due to the fatal outcome of the first BCL10 deficient patients and those MALT1 deficient and CAR11 deficient patients, the bone marrow transplantations appears to be the best treatment for these 3 related disorders. Thank you very much.
Thank you, Rebecca. That's great. So I get to ask the questions again. Please submit via the Q&A, folks, but I'm going to ask you some questions. So you said that transplant is going to be the treatment of choice. Is that available for this little boy?
Well, in fact, now they are organizing everything to make the transplant. It's not easy because it's a patient from India and the parents are not very collaborative. So, but we are trying.
It's difficult because he's quite old, isn't he? Did it surprise you that he would have presented at the age that he did?
Do you mean this patient?
Yeah, he's managed to keep going through childhood with conservative management. I know he's been quite sick at times.
Well, the progression of the disease that is appearing is very similar with the first patient that started at the same age. The first patient we detect with a BCL10 deficiency died with 3 years old. and started to have very similar pattern of infections. The only different thing is the first patient has a gastroenteritis and chronic colitis alterations, but this patient is only have respiratory infections. But the pattern is very similar with the first patient.
Sure.
So there are plenty of questions arriving. So I'm just reading from bottom to the top, sorry. So one of the question was the parents, the heterozygous parents are probably asymptomatic?
Asymptomatic completely, yeah.
And the other question was, are there any biomarkers or tests we could use to a fast diagnosis of this condition?
Well, the best is in both patients there is an hypogammaglobulinemia, and the T and B cells levels are normal. But when you analyze the memory cells, is when you detect a block in the T and B memory T cells. So I think is the best biomarker.
Thank you. Sophie, do you want to go?
Yes. So Jess is asking if the parents are asymptomatic.
Mm-hmm.
And there's also a question about whether gene therapy might be applicable to this condition.
So, sorry?
Would gene therapy be an attractive way of managing this condition if it were available? Maybe not in India.
Yeah.
Okay. Thank you. I think we should move on. I've now discovered how to actually read the questions. So thank you for submitting those, everybody. And thank you, Rebecca.
Thank you.
Thanks. Our next presenter will be Gonza Hancioglu. I'm sorry if I've garbled how to say your name. And we're interested to hear about NF-kappa-B pathway deficiencies, a single center experience.
Yes. Good afternoon. Thank you. I'm Gonca. NF-kappa-B pathway is one of the main pathway of immune and inflammatory responses. So I'm going to present our patients related to NF-kappa-B pathway. We had 15 patients, as you see in slide. Most of them had on an AIKB mutation, and others were NF-kB2, CART11, MALT1, MEP3K14 mutations. Our two patients deceased. One of them was patient 7 died due to attack of hemophagocytic lymphohistiocytosis, and also he had BCIitis. The other one was patient 10 died due to T-cell lymphoma. Actually, this patient was patient's 9th mother. She died 8 years ago, and in her clinical history there were recurrent respiratory tract infections, and so we evaluated her pathology samples again, and we diagnosed her with NF-kB2 related T-cell lymphoma 8 years after her death. Within our neonatal screening program pilot study, patient 11 was screened for immunodeficiency and was found positive. Therefore, NF-kB2 mutation was detected by genetic tests. Of these 15 patients, 65% had symptoms started in the first of year their lives. Most of the patients had parental consanguinity. Common clinical presentations were respiratory tract manifestations, lymphadenopathies, failure to thrive, and neurological findings, especially seizures and headache. Particularly the IKB-KB patients had autoinflammatory manifestations such as non-infectious fever, after the ulcerations, and enteropathy. And also 6 of all patients had some skin findings such as severe eczematous rash, nodular rash, alopecia, and Two of them had severe food allergies. The patients had some opportunistic infectious pathogens, as you see. And most of the patients in our study, total T cells and naive T cells counts were normal range for age, but memory B cells counts decreased. Currently, our alive patients are doing well with regular IVIG treatment. So HSCT has not performed yet. We have some conclusions about these NF-kappa B patients, particularly the patients with heterozygous mutations in IKB-KB gene seem like to have autoinflammatory diseases at presentation. The homozygous IKB-KB patient seems non-T-cell KIT. In the light of our findings, the patient's remarkable clinical manifestations were immune dysregulation, which include autoinflammation, autoimmunity, severe atopy, lymphoproliferation, and malignancy. So it should be taken into account that patients presenting with immune dysregulation findings may have NF-kappa B pathway deficiencies. Thank you very much for listening. Thank you.
Thank you very much. I have a question about the IKB-KB heterozygotes. Were you able to assess their parents? And how did you assess the pathogenicity of those variants more generally?
Patient 7 is homozygous IKB-KB. We have performed his family, and his parents had heterozygous mutation, and his mother had recurrent infections. And we have performed studies already, and we continue. Patient 7 and patient 8 were siblings. One of them is a heterozygous mutation, had heterozygous mutation, and his clinical findings were particularly better than patient 7. So we will perform studies.
Okay, that's great. I don't want to monopolize things, so a couple of other questions. One is about NK cells. Did the patients with low NK cells have a different outcome?
I don't understand.
Some of the patients had low NK cells, didn't they? And if so, did they have a different outcome? That was the question. Maybe they didn't. That's fine.
Yeah. Different outcomes.
Yeah. And were there any clues that led you to focus particularly on the NF-kappa B pathway in your diagnostic approach, or do we just have to screen all genes in all patients? Just quickly, and then this is the last question. Could you guess it was an NF-kappa B defect, or do we just have to screen all genes to find these variants?
Not all genes, but we know we have to perform whole exome sequencing.
Okay, then you won't miss them.
Okay.
Thank you very much. Thanks for answering all those questions.
Thank you.
And so our next presentation is from Kim Elsink in the Netherlands, and she's going to tell us about a national external quality assessment for NGS-based diagnostics of primary immunodeficiencies. Thank you. We can't hear you, Kim.
I'm sorry, but thank you. I'm very pleased to present to you the results of our National External Quality Assessment Study. I present on behalf of our co-authors. I have nothing to disclose. Well, we have performed our study as NGS-based diagnostics become more and more common within the diagnostic trajectory of primary immunodeficiencies. From our daily practice, we know that data interpretation of NGS output by clinical laboratory geneticists might be influenced by different factors, such as technical issues and staff experience, but also the fact that primary immunodeficiencies are not solely monogenic disorders. And we think that in order to guarantee high quality care for patients, it is very important to have uniformity in data interpretation among all Dutch, in our case, Dutch genome diagnostic centers. So the research aim of our study was to assess uniformity in variant interpretation in NGS-based PID diagnostics among Dutch genome diagnostic centers. And for the genetic workup of the patient, the country was divided in 3 regions, but there were 4 centers that participated in the quality assessment study. So the first step was the distribution of VCF files among all those centers. So each participating center received 2 VCF files and sent from all the centers, and sent 2 VCF files to all others as well. And then as a second step, we asked the clinical laboratory geneticists to interpret the VCF files and filter out the sequence variants that they would report to the medical specialist according to their own local pipeline. We also asked them to classify the variants. And important to mention here is that we did not provide any clinical information except for knowledge of the existence of a primary immunodeficiency. So what we did then as a 4th step was that we compared the outcomes of the variant interpretation to assess to what extent those were uniform and interchangeable among the 4 centers, the 4 GDCs. And as a last step, we also created a questionnaire for the clinical laboratory geneticists that participated in order to assess their experience towards this study. So when we look at the outcomes of the variant interpretation, we actually see that all variants that would be reported to the medical specialist in the center of origin would also be reported to the medical specialist in all the other centers. There were 2 exceptions when it comes to the classification in sample 1 and sample 3, which I will not discuss further here because of the time. There were some additional identified variants by the clinical laboratory geneticists, but also, I will not discuss this any further but these are extensively reported in our paper. So the questionnaire we sent out revealed that the lack of clinical information was considered a very big shortcoming, and this was also something that was mentioned by all participating clinical laboratory geneticists. And in addition, they also suggested to standardize the bioinformatic pipeline. So I think, according to the results of our study, we can conclude that data interpretation in NGS-based diagnostic was uniform within the Netherlands. The majority of pathogenic variants were identified and described correctly, and even if not all identified variants were the same among the centers, the most important were filtered out. So the ones that would be reported to the medical specialist. And yeah, I think the main message of our study is that multidisciplinary discussions and close collaboration between medical specialists on one side and the clinical laboratory geneticists on the other side are very important, especially in case of variants of unknown significance. And we hope this will lead to more harmonization and hopefully eventually also on an international level. Thank you very much for your attention.
Thanks, Kim. Thank you. That's very interesting. Why did you... Oh, so there's a question here. VUS versus likely pathogenic classification requires significantly different level of evidence. Were there lessons learned about this discrepancy?
I'm sorry, can you repeat it? I didn't hear the first part of
it's a question about whether lessons could be learned about the distinction between variant of unknown significance and likely pathogenic.
Okay, thank you for the question. Well, I have to mention that I'm not a clinical laboratory geneticist myself. But when it comes to lessons to be learned, again, I think what I said in the conclusion is that it's very important to have discussions and meetings with both medical specialists and clinical laboratory geneticists, but also clinical laboratory geneticists only them. Because in that way we can avoid such discrepancies in classifications among different centers.
Was there a particular reason why you did not provide the clinical information along with the variant? Because I usually think that's rather helpful, but maybe there was a reason.
Yeah, good question. Thank you again. Well, the quality assessment study was part of a bigger cost effectiveness analysis study, and we wanted to see to what extent it was possible to get a uniform outcome without providing clinical information. So we wanted to show how much clinical information is necessary in order to get a proper diagnosis. So that was the reason. We did not do that.
Thank you, Kim. We'll look out for your paper.
Thank you.
So I'm going to hand over to Anne now to introduce the next speaker.
Thank you. So sorry. So our next speaker is Adriana Albuquerque from UK, who is going to talk about validation of a functional diagnostic assay to define the pathogenicity of variant of unknown significance in the STAT1 gene.
We can't hear you, Adriana.
No sound.
Sorry, can you hear me now? So I have nothing to disclose. Gain of function mutations in STAT1 gene are the main cause of chronic mucocutaneous candidiasis, but it can also underlie other clinical presentations such as comoverbal immunodeficiency. Because genetic diagnoses are becoming widely available for primary immunodeficiencies, we need strong functional assays to validate variants of unknown significance in genes and to attribute diagnosis. So here we describe a flow cytometry-based functional screening methodology that defines the pathogenicity of STAT1 mutations in patients. For this, we compare 9 patients with variants of unknown significance in STAT1 gene and mutations that are not described in the literature with 4 group of patients. One group of 9 patients with previously described STAT1 mutation in STAT1 gene and the clinical phenotype of chronic mucocutaneous candidiasis that will be referred in the graphs as CMC. 5 patients with V266I mutation in the STAT1 gene that will be referred in the graphs as V266I. 18 patients with common variable immune deficiency and no STAT1 mutations that will be referred in the graphs as CVID, and 35 healthy controls. First, we show that STAT1 phosphorylation and total STAT1 expression are significantly increased in patients with variants of unknown significance in the STAT1 gene, here represented in the graphs in green. And these levels are similar to the patients that have previously described mutation in STAT1 gene, conferring a phenotype of chronic mucocutaneous candidiasis, here in the graphs in orange. 8 of the 9 patients with previously described mutations in STAT1 conferring chronic mucocutaneous candidiasis in orange show a very high levels of phospho-STAT1, which enable us to validate our phospho assay. 5 of the 9 patients with not previously described mutations, variants of unknown significance in STAT1 gene, show very high levels of phospho-STAT1 that could be consistent with the gain-of-function mutation in STAT1. We are also able to identify 2 patients with a loss-of-function mutation in STAT1, here in blue, as you see, that shows low levels of phosphorylation of STAT1 and a level of expression of total STAT1 similar to the healthy control. 1 patient in the positive control, the orange one, patients with previously described mutations that confer a gain-of-function in STAT1, had a fold change similar to the healthy control, suggesting that if we use only phospho-STAT1 assays to validate variants of unknown significance, we could be doing a wrong diagnosis. Next, we assessed the upregulation of CXL10 on monocytes and CD4 T cells of patients with gain-of-function mutations in STAT1 after stimulation with interferon alpha. You can see here on the left monocytes cells and on the right the CD4 T cells. And we were able to show in green, the dot greens, that patients with unknown variants of unknown significance in STAT1 gene are able to upregulate CXL10 at levels similar to patients that have been previously described as gain-of-function mutations, as shown in orange. The 2 patients with a loss-of-function mutation, shown in blue, are not able to upregulate CXL10 at same levels, and you can see that their levels are similar to the healthy control and also with similar to the patients with common variable immunodeficiency and no STAT1 mutations. Putting our data together, you can see in these graphs the levels of phospho-STAT1 and CXL10 in relation to the several mutations that we have in our cohorts, and we could show that 4 patients had a gain-of-function mutation in STAT1, and 2 patients had a loss of function in STAT1 that were not previously described in the literature, and this was based on the concomitant increase or decrease of the levels of phospho-STAT1, STAT1, and CXL10. Our data also suggests that CXL10 quantification is a better marker than phospho-STAT1 levels for the functional validation of STAT1 variants of unknown significance, as all patients that had a high total expression of STAT1 we're also able to upregulate CXCL10. Interestingly, all patients that have a gain-of-function mutation in STAT1 have a clinical phenotype of chronic mucocutaneous candidiasis, while the 2 patients that we identified as having a loss-of-function mutation do not have infections with Candida. So in conclusion, we show that a combined flow cytometry-based measurement of baseline and interferon alpha-induced STAT1, phospho-STAT1, and CXCL10 in CD4 and monocytes could represent a useful marker for functional validation of STAT1 variants of unknown significance. I would like to acknowledge everyone that contributed to these projects at UCL, especially Siobhan and Emma, all the clinicians that have sent us samples, to the patient and healthy controls, and you for listening.
Thank you, Adriana, for this presentation. So one question is, what's the phenotype of the V266I mutation? What's the different category of, is it in a different category than the gain-of-function mutation?
Yes, so all the patients that we found to have V266I mutation in STAT1, they are all patients that have common variable immunodeficiency and don't have a phenotype of chronic mucocutaneous candidiasis.
Regarding this amino acid, I thought it was neutral, this amino acid. In many experiments, I thought it had a neutral activity on STAT1 activity.
Yeah, so if you remember the graphs, so if you compare the patients with the V266I mutation, it's not clear if they have clinical obvious increase in the phospho-STAT1. It looks like it's relatively increased in relation to the healthy controls, but they are not at the same levels as the other patients that have a gain of function for sure.
And I have another question, so maybe and then we have to move on. So at the very end, so when you're looking at CXCL10, so maybe I'm wrong, but it seems that it wasn't in the patient with STAT1 gain of function and CMC. The phosphorylation of STAT1 was a better marker than CXCL10 because it seems that you had patients with low CXCL10 induction.
So there are 2 patients with that in the graphs, it looks like they have a very low level of CXCL10. The reason is that those 2 patients have a really high level of CXCL10 at background, so before I stimulate the cells. So I think it's a huge value. So I think when I stimulate with interferon alpha, as it's already very high at baseline, they are not able to upregulate at same level as the others.
Okay, thank you. Thank you.
Thank you.
So the next speaker is, Atina Furiki from Switzerland, who's going to talk about 3 cases of TRIPEPTIDYL peptidase 2 deficiency caused by a novel founder variant.
Thank you. Hello, my name is Furiki Athina, and I'm a pediatric immunologist at the University Hospital of Lausanne in Switzerland. I would like to take the opportunity to present you 3 cases of TPP2 deficiency. I have nothing to disclose. This is the acronym for TPP2-related immunodeficiency, autoimmunity and neurodevelopmental delay with impaired glycolysis and lysosomal expansion. In our hospital, we are caring for 2 siblings and a young adult who present a complex syndrome with manifestations similar to triangle disease. Even though there is no reported family history of consanguinity, these 3 patients come from the same Swiss Valley. First of all, I would like to present you the 2 children and the manifestations that they have in common. As you can see on the table here, they present a psychomotor development delay, a small head circumference, hypoplastic teeth, recurrent and chronic ENT infections, as well as infections of the skin and autoimmune manifestations. In sibling 1, which is a boy of 8 years old, we note additional manifestations of autoimmunity and notably autoimmune cytopenias. Thrombocytopenia was the most refractory one and needed a treatment with corticosteroids in addition to the intravenous immunoglobulins. In sibling 2, who is a girl of 5 years old, we also observed a universalis alopecia and xerophthalmia with autoimmune manifestations. She had a late umbilical cordon fall, and she presents also recurrent oral afta, tracheonychia, and port wine stains. In the laboratory findings, we observe increased inflammatory markers, mild lymphopenia and monocytosis, low B-switch memory, CD4-RT and CD8, and isolated hypoglobulinemia M and positive autoantibodies in both siblings. Then we can also see some difference on the lab test, as you can see here. In the adult patient, we have several similar manifestations, which you can see on the left-hand side table. Nevertheless, it's important to underline that there are clinical manifestations which do not exist in the children and can express either additional findings or the evolution of the disease in adulthood. As you can see on the right-hand side table, the adult further presents other neurological manifestations and in particular a moya-moya-like vascular disease, calcifications and multiple ischemic strokes. He has also experienced more serious infections and long-term consequences of the chronic or recurrent ENT infections. In addition, he presents some gastrointestinal manifestations and other signs of autoimmunity. In the family history, it's worth mentioning that an older sister of his died at 20 years old and had the same clinical manifestation. At this point, it was assumed that there was probably a homozygous disease, and thus we performed the combining homozygosity mapping on exome data of siblings and genome data of the adult, where we found that all three share a common region of homozygosity on chromosome 14, containing a missense mutation for propionic acidemia. However, as this disease does not explain their manifestations, we went on searching for any structural variants and found one deletion involving coding sequences. The three patients have a homozygous deletion within the TPP2 gene, removing 4 exons and leading to a frame shift with premature truncation of the protein. To date, mutations of TPP2 gene have been described in 8 patients all over the world with autoimmunity as common manifestation. In addition to the 2 original families and the described phenotype of triangle disease, 2 siblings from another family presented with primary immunodeficiency and early onset Evans syndrome. Contrary to the patients described above, 2 siblings from another family showed a milder phenotype with brain inflammation, mimicking multiple sclerosis. The observations described here reveal a new founder mutation leading to TPP2 deficiency, extend the spectrum of clinical manifestations of the disease, and provide the opportunity to document its possible age-dependent clinical stage of evolution. Thank you for your attention.
Thank you. So I may have missed something, but within the deletion, are there other genes which are involved or only TPP2?
Excuse me, can you repeat, please?
So you have a deletion, correct?
If we have, excuse me?
So you have a deletion in those patients, correct?
Yes.
And
yes, exactly.
I was wondering if within this deletion, are there other genes which are involved, which could be deleted in this family?
No, it was the only one gene which was deleted.
Okay, so clinical manifestation is really due to TPP2 deficiency only.
Exactly.
Are there any questions in the audience? No. And so as compared, so I miss as compared to the 2 first family described. So your patient. So what the different? What is what do your patient? What do your patient present in addition as clinical phenotypes?
So they have a lot of similar manifestations, and exactly they have recurrent ENT infections, low tract infections pulmonary infections. They have also a lot of similarities about the autoimmunity manifestations, and exactly they have also one of them. They have also an autoimmune cytopenias, which is described in the first two families. And we have also the adult patients, so we can see the additional manifestation of the disease in the adulthood.
And how can we treat those patients?
So for the moment, we are waiting for transplantation if we can find donors, but otherwise there is no other treatment for the moment. They have tried to give the substrates of the enzyme, but it doesn't work.
Okay, thank you.
Thank you.
So we move on to our next speaker, Marielle van Gien from the Netherlands, who's going to talk about the results from the first international external quality assessment of genetic testing for severe combined immunodeficiency.
Okay, thank you very much. Then I will go. Okay, thank you very much for inviting me to talk about something more clinical, diagnostic-wise. The genetic diagnosis is an essential part of the SCID diagnostic workup, actually. So far, there's no... Is it moving for you as well? So far, there's no external quality assessment for genetic testing for SCID, for immunodeficiencies in general. And external quality assessment is necessary for clinical laboratories. If you don't participate, if you perform not good in those schemes, you might lose your license to perform clinical testing, clinical genetic testing. So that's why we, ARN Rita, together with the AMQN, organized the first SCID AQA pilot. And what did we do? So together with the AMQN, we invited people to participate in the pilot. In the end, this resulted in 18 participating laboratories, 3 laboratories from the UK and 3 from the Netherlands, and then from various other European countries, including actually Australia and Brazil. Those labs participated. What we did, we sent around 4 DNA samples with mock clinical scenarios for the people to test. And the samples included variants in different genes relevant to SCID. We then judged, they sent back to us their lab, the usual letter, the report they write to the clinicians. And we judged these reports on 3 categories: on the genotyping to see if the detection method really detected the mutations, the interpretation of the genetic variants they detected, and the 3rd category was patient identifiers and clinical accuracy. Specifically in diagnosing and in a clinical setting, this is rather important. And for each category, we had a score of maximum of 2 points. So then here the results. So luckily we didn't detect any critical errors in genotyping, interpretation, or clerical accuracy. What we did notice that the people use different panels. So it's for NGS testing mainly. And what we saw that some labs, you had huge panels, over 400 genes, and even some candidate genes in them. And you had laboratories that participated with just small SCID-related gene panels. So there's a difference there. And for the interpretation part, we had some errors we detected. So in the first case, there were no pathogenic variants detected because they were not supposed to be in there. In the second case, we had an ARA2 compound heterozygous case. We had a homozygous X-linked SCID case in the third case, and in the fourth case, we had a carrier, so the mother of a patient to be tested. So the interpretation errors were mainly because they didn't conclude anything regarding the suspected diagnosis of SCID. Just reporting that you find DNA variants is not sufficient. You really have to make the interpretation in your clinical cases and if you can diagnose it or not. We also detect some overinterpretation of variants and unwarranted referral to counseling. Especially in the first case, there were 4 labs that did report variants of unknown clinical significance, and in some cases, they were not at all related to the SCID phenotype and could never give a diagnosis. And we had the X-linked inheritance in case 3 was not clearly stated in certain reports because it's a different inheritance than a general autosomal recessive, and it has different risks for the family members. And also some clinical labs are not used to carriership analysis, so they misjudged the counseling case for that not as a carrier, but they could not conclude their diagnosis that she was not a patient. So the last and I think the most important thing we noticed that there was a high variability in reporting and interpretations of the variants of unknown significance. So some people report many of them. Some people do not report any variants of unknown significance, and also the interpretation is, of course, rather difficult. So to conclude, so the overall quality of genetic testing for SCID is the ones we tested at least is of excellent quality. So I'm rather happy about that. And there are no guidelines what to do with a FUS and how to report a variant of unknown significance. So I think that's really warranted, that we need a European, so not only national guidelines, how we should report FUSs. And so far we've done this pilot, and now the SCID AQA has become an official AMQA scheme. So for next year and in the coming years, you can just register and participate in the SCID AQA scheme. And my acknowledgement go to the team. We did this as an AR and Rita team, and the ones participating in the pilot to judge the reports were Mirjam van den Burg and Annette Simons. So I would like to thank them as well. Well, thank you very much.
Thank you, Marielle. So we have a question. So who in your view is responsible for the interpretation of the clinical significance of views found? The laboratory leave it to the clinician, or is it a combined effort?
I think it's a combined effort because especially with immunodeficiencies and the non-penetrance factors often there. So it should be a combined effort. That's why I'm always in favor of multidisciplinary interpretation teams and stuff. But lots of things there are. If you can really judge pathogenic and likely pathogenic, that's things you can really that are more clear than the others. I think the most important, difficult variants are the ones you're not really sure of and that needs further functional testing or further family segregation analysis.
Thank you. Another one. So some labs have SCID panels for positive tracks and quick tracks. Could this be used for your study?
Which?
The tracks.
The neonatal screening, you mean? The track, yeah. This could be secondary. What we do is we test the genes, so we don't do any track analysis in there. So I think there might be a scheme there as well. But the outcome of the track is that if that is negative, then you should perform genetic testing, and then this is the things we are testing with our AQA.
And I have a question. So you were saying that some labs were using small panel for SCID and others were using larger panel. Have you seen any difference in between the small panel special for SCID and over 400 genes panel?
Yeah, the risk of a big panel is the overinterpretation of variants which are not related at all to SCID. That's what we noticed. So in that case, you would be in favor of a small panel at the first glance. But in a way, if you don't report, if you do, what we noticed that the labs would perform the big panel testing, they had VASs, and as long as they didn't say this is conclusive for SCID or this explains the phenotype of the patients, as there are no guidelines how to deal with that, we could not. So it was still okay. So you see differences there, yeah.
And the last question, so patient at SCID phenotype with the patients with SCID phenotype compatible with genetic identification? So the patient for whom you have identified a genetic potential SCID, do they have a SCID phenotype?
Yes, they will. Because we collected samples from real patients, but the clinical scenarios were just made up by us. So it's by the teams. So they should meet a patient with a YAC3 or another phenotype, especially for the case without a genetic phenotype. We took good care. So they were not real. They were not the real descriptions of the patients themselves.
So I don't know if it's time to close or not. I don't know. Sophie?
We still have one more presentation, which is Vasilios Bougaris, the Italian Registry for Primary Immunodeficiencies, IPINET, 20 years of experience. Sorry, Vasilios, why don't you take it away?
Sorry.
We don't hear you at the moment.
Can you hear me now?
Yeah, unmute. That's it.
Okay, perfect. Sorry for that. Thank you for the introduction. As anticipated, I will be talking about the IPINET experience in the field of PIDs registry. I have nothing to disclose. More than 20 years ago, here in Brescia, a small number of pediatricians and immunologists decided to create a national registry for primary immune deficiencies. This had the objective, the initial objective, to better understand the natural history of PIDs, because not much was known back then. And this also included the idea to share a diagnostic and therapeutic protocol for each kind of PIDs throughout the Italian territory. In order to do that, all referring clinicians should update patients' data at least once a year, and each year new patients should be registered. As you can see on the left-hand side, going from 1999 to 2019, in over a 20-year follow-up period, the number of patients exponentially grew, and we reached almost 3,400 patients by now. And this allowed us now, after 20 years of experience, to define the minimal prevalence of PIDs in Italy, something that had not been done before. As you can see on the left-hand side, Italy has more or less the same minimal prevalence with other European and non-European countries, although it seems lower when compared to some other national PID registries, also with different numbers. What kind of PIDs do we see in Italy? As you can see, and as you would expect, the majority of PIDs in Italy are primary humoral immune deficiencies, starting with CVID, selective IgA deficiency, and then we go with a gamma globulinemia. On the other hand, we have a lot of, let's say, syndromic PIDs, such as DiGeorge syndrome or Wiskott-Aldrich syndrome. And the numbers of immune deficiencies related to, let's say, the innate immunity appear, at least in the national registry, not to be so much, let's say, numerous. The importance of this registry is also to understand how many of the patients that we do, let's say, register are still alive or not. So after 20 years, and out of these 3,352 patients, more than 90% of the patients are alive at last follow-up, and only a small number has been lost during follow-up, many times due to patients' will. Based on the latest EIUIS classification of 2019, you can see, as I anticipated earlier, that antibody deficiencies represent more than half. But the interesting thing is that we have quite an important percentage of combined immune deficiencies with other associated or syndromic features, something that is probably coming up also in other registries, even bigger than the Italian one, like the ESID one. And as I said before, other diseases like immune dysregulation and so on, or bone marrow related ones are less depicted, probably also because other national registries, depending on the pediatric hematologists, account for those ones. Finally, we went to actually see how the death incidence was in Italy was when we could compare that to other published data. And as you can see, Italy is the black one in this graph. The death percentage in Italy is very lower than most other published registries. This may depend on different issues, such as, for example, in Tunisia and Morocco, where you have a lot of consanguinity and a lot of specific SCIDs that clearly are more related to early mortality. And on the other hand, our death percentage is very similar to what we see, as I said, in most European countries. Concluding, this is to say that PID registries are essential in order to better understand the natural history of PIDs, which in the end can allow clinicians to better understand the disease and can offer better quality treatment and better quality of life for affected patients. Of course, this can only be, let's say, accomplished with a complete effort from all referral centers. And in fact, now in Italy, it's more than 60 centers. So in Italy, PIDs are something that we really care for, and we hope we can do better in the future. Thank you.
Thank you, Vasilis. Thank you so much. So there is one question. So for patients with IgA deficiency, did you include only symptomatic patients or all deficient patients?
So actually, most of the times when we see patients with selective IgA deficiency, they are symptomatic or they are screened for IgA when they do celiac disease screening. Most of them are symptomatic or they have a familiar history for a selective IgA deficiency. So it's kind of biased, but that goes for any kind of mild primary immune deficiency.
And the one is, how do you calculate mortality rate? 4% is total of all disease PID patients during the 20 years?
So mortality rate was based, mortality percentage actually, not rate, was based on the total number of dead patients over the 20-year follow-up. And that is the way it was calculated for the other papers that were included in the graphs you saw. So basically, we use the same calculation as in the other published PID registry papers.
So there are questions popping up, but what percentage of patients with primary antibody deficiency were found in your registry with a genetic defect?
Okay, yeah, that's a good point, since we're talking about genetics. Basically, the thing is that initially, the genetic was not part of the registry, so most patients did undergo genetic diagnosis, but initially it was not included in the registry. So we have a lot of genetic diagnosis, including NF-kappa B1, 2, TACHI, BAFAR, all the genes that we know of in primary antibody deficiencies have been screened, and we have patients from all that. But in this paper, we only wanted to give a picture of how PIDs are in Italy, and we did not want to go into depth for the genetics.
Okay, we have to finish. So I would like Sophie. So we would like to thank all the speakers and the participants, and I hope you enjoyed the session. And thank you so much.
Thanks, everybody.
Thank you.
Bye.